Okay, we're going to resume our conversation. So, Chandra, you told us about how care is actually going to sub centers in rural India, sharing your app and your medical team. I mean, it's not just an app, you have a team of specialists behind the app that are able to provide telehealth consultations through a local community health worker or nurse. So they're working with local community healthcare worker or nurse. Who are the people working to provide the specialist care on your app? Are they the local doctors from the city in India? Who are the people that are working on your app?
So currently we are implementing this model, as I said, in a place called Kerala. So the doctors are being facilitated by, I would say, multi-speciality hospital in Kerala called NIMS. And so basically, what we are doing as a startup, we are actually going and presenting our model to them, and they are also finding it very unique for them, because for them there are a lot of patients who travel from very remote villages and they find it very difficult to come there as well. So some of these multi-speciality hospitals, which are quite big in the cities, so they are willing to give us, and actually we have onboarded all their specialist doctors on our app. So in this specific example which I'm talking about, is that the way we are operating here is we will have a GP as well in that telemedicine center, and we will have a qualified nurse and a general physician who's basically like probably just a junior doctor who's probably passed out and has 1 or 2 years of experience. Now, these specialist doctors who are provided by this multi-specialty, I would say, hospital, we have onboarded all of their doctors on a platform. So each doctor, like each specialist, has given specific day of their availability, right? They said like a pediatrician is available every day for say 1 hour, a certain slot, right? Or I would say a cardiologist is available every alternate day. A gynecologist is available every alternate day for a few hours. So like that, we've been able to bring in all the specialty doctors on board. And the idea is every patient who walks into the rural clinic, the GP, obviously, with his experience, he will do the primary checkup, primary diagnosis, and he's the one who's going to decide whether this person needs a specialist. So, not many patients who come are required to have a specialist doctor every day. So, ideally, like even every day, if they have to have at least say 5 to 10 consultations or 5 consultations of specialists, so there are there. So this patient walks into the center, they have this problem, and think the doctor thinks that they need to see an orthopedician. Then the health worker will see the calendar there, they'll see there is a this doctor who's available on that particular day, so they'll book a slot. They'll ask the patient to come back next time again on that same day. Typically it's just a difference of 1 day, so they'll come back and they'll facilitate the entire call. So that's how we have been able to manage, because most of these specialist doctors are super busy. When I went there to onboard them on our platform, each of them actually gave me exactly 2 minutes of their time. So that's how busy they have been, right? And one of the ENT specialists was like literally wearing all her gadgets, and she was busy. So because whatever time they are in during the working hours, I mean, they see so many patients, like hundreds of patients every day, right? So it's really impossible. But so that's where we are trying to find a time when probably during their travel, when they have time, or after their work when they have some time, probably 1 hour or 2 hours, whatever time slot they are able to give. So accordingly, we are able to onboard them on our platform, and obviously the great it's all because of the great effort of the hospital management itself, because they are the ones who believe in this. They also feel like they need to serve the communities, and as a hospital, I also they provide a lot of these I'd say subsidized care, or would say they help a lot of community members as well who are unable to pay and all. So they have seen that I would say they see that there is a value in this. So that's how they are enabling, or I would say they are offering those doctors. So we have onboarded all of them on a platform. So this is how it's happening now. It will be a physician who will be sitting at the center, and they can now connect to all these specialist doctors from that center itself without patient moving or neither the specialist coming to them.
Yeah, that's incredible. So you're taking the specialists that are in the community health center, which, is 30 to 60 kilometers away from the patient, and connecting them to that sub center that's a couple miles from their home where they can access healthcare within a day. Have you had any difficulty? I mean, what is motivating these physicians in the community sub center to want to participate in helping through telehealth the community? And have you had any difficulty getting people to want to be part of the program?
Uh, so right now, this is all the engagement is purely private. I mean, we are not currently working with the government. So all these players are private players, and I believe the hospital which is willing to give their specialists, they have been very, I would say, supportive. They believe their responsibility towards society, and they want to bring a difference. And in a way, I think it could be an opportunity for them as well. If you see a larger perspective, because anyone who needs an advanced care, right? So end of the day, they can turn up to their hospital itself, right? Basically, in a way, what they're trying to do is, instead of the patient coming all the way to their hospital, they are enabling that access from that village itself. And if that person needs an advanced care or a specialist care, or I would say, if he needs to get admitted for whatever reason, so they are able to provide that benefit, right? So yeah, and obviously, so most of these people, they do have the I would say, most of the below poverty line people in India, they get insurance from the government itself. So in a way, they are not getting the people are not paying that money, right? But still, hospitals are getting paid because of the insurance which they avail from the government, right? So yeah, so in a way, I think in a larger perspective, there is a business opportunity for them, because a lot of these patients can end up in their hospitals at the end. But also, they're trying to kind of build this satellite clinic, I would say, right? Where they can get leads in a very, I would say, very rudely, if you put it. So they're kind of marketing their hospital in those villages.
Yeah, that's great that you are creating that opportunity. Actually, you're literally building up the local infrastructure by bringing telehealth expertise from further away. We've heard from previous guests that we have interviewed how important it is to engage with the local government, the Ministry of Health, in order to get your projects not only make sure your projects are in line with what their goals are, but to make sure your project is supported and follows their guidance. How have you engaged with the government or the Ministry of Health with your work in care?
So luckily, from the day one, since the time we started building the technology, working on the technology, so we started exploring how we align ourselves with the government of India. So basically, they have a department called NHA, National Health Authority, which is the prime make decision maker on the framework and or the compliance related requirements. So what we have done when we started building our technology, we have ensured that we are aligned with them. So they have, we are actually fully certified by them. So there are different levels of certification under them. They're called Ayushman Bharat Digital Mission. So this is obviously the flagship program of the Prime Minister, current Prime Minister of India. And so what they wanted to do is they wanted to kind of create a kind of a revolution like UPI. I would say unified payment interface. I'm not sure if you've heard, like where we are able to now even the smallest shopkeeper can get the payments digital in a digital way, right? I mean, I can just scan the code and make the payments, right? So nobody in India now exchanges money. So there's no transaction of cash transaction is almost like negligible now. For every small thing, I pay through my digital wallet, I would say, where I can transfer the money directly to their account just by scanning the QR code. Now, the similar kind of uh, infrastructure they want to build in healthcare. That's the reason they are creating something called Unified Health Interface, which obviously it's a long plan. Now, one of their objective is when they started this framework, I would say approximately 2 years ago, when the government had started, um, they called this framework called Ayushman Bharat Digital Mission. So under this, they have created something called ABHA. ABHA is Ayushman Bharat uh, Health Account. So it's just like an health ID. So in India, obviously, we don't have anything like a health ID, or I think I would typically like in US, right? Like if you give your social security number, uh, they will know your past medical history and where you have been, which clinic you have been, what kind of medicines you've been taking, right? Maybe I'm hoping that kind of information is available. That's exactly what the government of India is trying to do. They have created this. Already there is an infrastructure. I would say there is a unique ID with every individual in India, and on top of it, they wanted to create this layer of health ID. So when they created this health ID, the idea is to kind of retain or maintain medical records in that health ID. So today I go to a particular facility or I would say hospital and they treat me. They obviously generate some medical records. They should be able to link it to my health ID. Tomorrow I go to another hospital, and that hospital, if they want to retrieve my past records, they should be able to do it without asking this hospital, right? So that's a kind of interoperability they have built, wherein that second hospital will just punch in that particular health ID and it will retrieve all this data. Now, to kind of make it happen a reality on the ground, government obviously needs a lot of these digital players, or I would say HMIS systems, ERP, I would say, sorry, EMR, HMIS, hospital management softwares or electronic medical records softwares. So they actually have to come into existence, and they are the ones obviously who can drive this. And that's when the government of India started trying building partnership with such partners. So we are also one of their partner, where they have done, I mean, several levels of scrutiny. Like they've done functional testing of our app. They have done security testing, ensuring that there is no data leakage. They have done several audits. Then finally, they have made us do demos, several demos to the NHA people itself. And then after they verified, validated, they finally given us a stamp that, okay, you are aligned with the. So what is happening here is in the back end of our software, they have given us an API. So what it does is, if a patient comes to me today, to my clinic, I'll be able to create their health ID with this linkage. So in the backend already, I'm integrated with NHA with their framework. So I put in their existing, I would say, kind of social security number there. We call it Aadhaar. I put it there, I put there, and then I'll be able to generate a health ID instantly. Now, if I generate any medical records, I can also link them to that instantly, right? So that kind of alignment we have been able to do as a digital partners, several other multi-specialty hospitals, or I would say big brands or all these clinics, hospitals, everybody is aligned with that framework. So, in a way, with the help of, I would say, the consent of the patient, you can always have access to those records. So, coming back to your questions, I try to kind of give you all this, but we have been able to have that compliance and necessary requirements, and we are hoping to participate in some of their projects as well, right? End of the day, unlike the payments, healthcare is very difficult, and it's not easy to get adopted. So we are also trying to engage with them on some of the projects where we are trying to increase the adoption of this health initiative, I would say.
That's incredible. It sounds like you have a universal healthcare system, and now the Ministry of Health is working to make sure that the medical record system is also unified. I know a lot of people in America assume that we have that here, but we do not. We are not an integrated healthcare system. We have lots of electronic medical records, and none of them speak to each other. So if you go to the hospital down the street and you get seen, and then you go to the hospital across town, they have no idea what happened at the other hospital because all the companies are competing with each other and do not share or speak the same language. So it is that is an incredible innovation, and perhaps you'll be doing it for us one day.
That's great to hear.
uh, yes, we are not leading the pack on that one here in the United States for sure. Chandra, what would you say are the greatest healthcare needs and inequities that still exist in the communities you're serving, and that need to be the priority?
I think even though we say that government, I would say every government is doing their bit, but the challenge is if you look at the demographics of India, literally, I would say 68% of people live in rural villages, right? And so it's hardly like any 30% of people are in the urban areas. Every other invention, discovery, everything happens for them for the urban areas. What we do for the rural is very, very, very little, right? I mean, whatever new age gadgets or new age AIs, whatever you bring, right? Nothing serves them. So, I mean, there needs to, I mean, there's always like a 0 to 10. So, urban is at 10, rural is at 0. And so that's the kind of difference is there. So, opportunity is tremendous. Obviously, biggest challenges are you can't really build proper revenue models. You'd have to find ways wherein you have to partner with different organizations, or I would say communities, to come together and build some models. That's what we have been trying to do. Obviously, you also need to engage with the state governments, and also local governments, as you rightly said, to or explore those opportunities. So I think there is a tremendous opportunity. I would say not only in India, I think across the globe, it's almost the same case, right? Most of the, I would say, most of the world is developing. There are only few countries who are developed, right? So we see this an opportunity, and for that matter, actually, we've been able to kind of pitch it to some of the I would say groups in Kenya. So we are actually now piloting in Kenya, again the same model, because one of the best case study there we found is there's one NGO which works for the obviously equitable healthcare. What they do is they try to bring a specialist to their village once in, I would say, once in a week, and that doctor comes from a city, and he spends almost like 2 hours on the road to come to his that village, right? When he reaches there, he only spends around like maybe 15-20 minutes, and then he leaves. He's literally spending almost like 4 hours to for in his travel, and the quality time he can give is probably hardly 30 minutes. So we found a good opportunity there. We pitched our solution. They also liked it. We are yet to start the pilot, but the case study is there that we've been able to now talk to a local, I would say, some of the local hospitals in the city, and they also agreed and appreciated this model because for them it's always been very challenging to reach out to those communities in the remote villages. So with this model, again, they are able to find that way. So as I see, there are opportunities not only in India, across different regions. It's all about proving the model. For different region, obviously, you have to slightly tweak it, but not so much. But yes, there's a need, and there's a lot to be done.
We have so much to discuss. We could go on and on. I want to give you a second to please tell our audience how they can connect with you and or care if they want to connect.
They can definitely reach out to me. I'm on LinkedIn, or they can simply go to CAARE.in. It's the website, and the contact number is mine. The email IDs are managed by me. So yeah, they can reach out and write to me there.
Excellent. If you enjoyed our episode today, please share it with a friend who you think would also enjoy this topic and conversation. Please also leave us a review, as we'd like to hear your ideas and feedback. If you'd like to be a guest on our podcast, email us at info@haew.org. And if you'd like to learn more, join us, partner, or donate, please go to https://haew.org.